had a cheat sheet here. So I'm going to see if our first presenter, Dr. Tonelli, is here. So why don't you come on up and we'll get started. Oh, I guess I could have said who you would. I'll let you in.
No problem. Right. Okay. Hello, my name is Chelsea Tonelli, and I'm a surgical resident at Loyola University Medical Center. Thank you for the honor of the podium and the opportunity to present our work, a contemporary matched cohort comparison of robotic, laparoscopic, and open approaches to elective inguinal hernia repair. The contents of this presentation do not represent the opinions of the VA or the US government. There are currently 3 surgical approaches to inguinal hernia repair: robotic, laparoscopic, and open. While this is a commonly performed operation, especially in the veteran population, few studies completed have sufficient power to compare the 3 modalities. Of specific interest is hernia recurrence, which no prior studies have evaluated with a large cohort. Now that robotic approaches have been incorporated and adapted across the country, we are able to assess the quality of the surgical repair, which we aim to do in this work. We hypothesize that both hernia recurrence and complication rates are similar, independent of surgical approach. With this in mind, we set out to determine if minimally invasive techniques are achieving equal outcomes and recurrence compared to the established open technique. In addition, we aim to evaluate the temporal patterns of surgical approaches over time. To accomplish these tasks, we utilize the Veterans Affairs Surgical Quality Improvement Program Database, or VASQUIP. We chose to evaluate a contemporary cohort from 2013 to 2017 of patients who underwent an initial repair of an uncomplicated inguinal hernia. The period was selected to allow for at least 2 years of follow-up. Exclusion criteria are listed, including female patients and those who are presented with an incarcerated, strangulated, or sliding hernia. We utilize propensity score matching in a nearest neighbor method to compare the 3 surgical approaches. Our outcome of interest was reoperation for recurrent hernia during the follow-up period, determined using procedure codes and unique scrambled patient identifiers. If a patient that underwent an initial hernia repair during the study period later underwent a procedure for a recurrent hernia, they were categorized as having a recurrence of their initial repair. Secondary outcomes of interest included operative time, urinary tract infection, discharge to a facility, and occurrence of a postoperative complication. Composite scores were created to indicate whether a complication was surgical or medical in nature. We identified 39,358 initial hernia repairs performed during our study period that met inclusion criteria, of which 84% were performed open, 16% laparoscopically, and 1% robotically. There were 25 facilities identified as performing robotic hernia repairs during this period. The patients in the open cohort were older by 2 years and had higher ASA classes and rates of COPD. Minimally invasive cases had significantly higher rates of bilateral hernia repairs. Over the course of the study period, there was increasing utilization of minimally invasive techniques. In 2013, only 13% of cases were performed with minimally invasive techniques compared to 20% in 2017. We next look at the operative time between surgical approaches. Independent of whether a bilateral or unilateral hernia repair was being performed, the robotic approach was significantly longer than the laparoscopic or open approaches. In our analysis of reoperation for hernia recurrence, we found no significant difference between the laparoscopic and open approaches in terms of time to recurrence, as seen here. The median time to recurrence in the open group was 16 months compared to 17 in the laparoscopic group. The robotic group is not demonstrated in this figure as there were only 2 recurrences during our study period. We completed a 3-to-1-to-1 propensity score matched analysis of surgical approach, which identified 1,026 patients in each group by scoring for the factors listed below, including age, body mass index, and bilaterality. The longer operative time in the robotic group is again demonstrated here. However, this does not translate into higher rates of adverse outcomes. The rates of complication, whether surgical or medical, were similar between groups. and the rates of reoperation did not differ between modalities. Our study is limited by the constraints of our data, and as a result, likely contains a selection bias. Although this is one of the largest robotic cohorts published, it still contains a relatively small number of robotic procedures. Given that our definition of hernia recurrence requires reoperation, the recurrence rate is likely understated. Our VA population and choice to exclude female patients may limit generalizability. In spite of these limitations, and given the results thus demonstrated, we have concluded that there is increasing utilization of minimally invasive approaches for inguinal hernia repairs. Our study re-demonstrated the findings of prior work that robotic approaches prolong operative times. We found that minimally invasive approaches are not associated with an increased likelihood of undergoing reoperation for hernia recurrence, and demonstrated no association between surgical approach and postoperative complications. Thank you again to the Western Surgical Association for the opportunity to present our work, and I welcome any questions at this time.
This paper is open for discussion. Go to over there. Please introduce yourself and where you're from.
Good morning.
Morning.
J. Craig Collins, Los Angeles, California. Congratulations on a big study that will be widely quoted. There are some other big studies that are still widely quoted years after the fact. And congratulations on achieving an exemplary recurrence rate, even though it's defined by reoperation. Less than 1% is a great benchmark to shoot for. I have two observations and associated questions. So the first is, your patients are a lot skinnier than mine, and they smoke a lot more than mine. Did you do any prehabilitation in terms of getting them to stop smoking? And the second question is, I noticed that your secondary outcomes did not include the appearance of pain associated with hernia repair. And when I counsel patients, that is what I tell them is the Achilles heel of this operation, that regardless of all the measures we take to prevent it, still somewhere around 1 or 2% of people will need the attention of a pain specialist at some point. So prehabilitation, post-operative pain. Thank you.
Thank you for that question, or those questions. So given that this was a large database study, we didn't have the opportunity to do any counseling or kind of further assessment or preparation for the surgery. So it was kind of, this is the patient cohort we had, and we tried to adjust for things that were going to like grossly skew our data. So that kind of limited that, and the VASCOP does have a variable that identifies neuropathic pain. We didn't get into detail with that. I know that's one of the common patient-centered outcomes that people review, but it's not one that I think gave any, sorry, I'm trying to think of the right word, like strong indications either way in our analysis.
Okay.
Thank you.
We're going to have short questions. We're going to start with Dr. Ujiki.
Yeah, Mike Ujiki, North Shore University in Chicago. Wonderful presentation. Thank you for showing us that data. Full disclosure, I do not use a robot for hernia repairs, and I feel that a laparoscopic approach is better. That's just my opinion. But I will say I would be careful, and I don't know if you can adjust for this, but there are a lot of surgeons out there who will use the robot for difficult inguinal hernia repairs. So for example, somebody with a previous prostatectomy, previous colon surgery, previous pelvic surgery. And so, you know, these might not be equal cohorts of patients. And so I don't know if you can control for that, but that might be something you want to look into when you publish. Do you have any comments on that?
So we definitely, I understand this is something that I think with any large databases, at least in my experience, it's hard to control for the technical difficulty of any operation if you're not there, if you don't have comments from the surgeon. We tried to identify and adjust for factors that we thought would lead to a higher recurrence rate or a more difficult surgery, so that being a smoker, higher BMI, and factors such as that. But I think one of the limitations of a database study is always not knowing the technical difficulty. So thank you for that comment. It's something we, I think, continue to grapple with.
So we'll go to this microphone and then back over in that, but very short questions, very short answers.
Good morning, Dr. Bukhari, Cook County Hospital, Rush University Medical Center. So one of the things we've been looking at is how do you define the surgeon? Like, what's the skill set involved in the results that are being driven? Any idea on who's doing the robotic surgeries versus the traditional ones? Are there a lot of them being done by older surgeons, the open ones, and so does this imply that the robotic surgery is even better than what we think it is, the less experienced people are doing it? Have you looked at surgeon traits?
Yeah, that is not something that we explored at all in this. It's definitely, I guess the way I think about it is my mentor and the primary author is a more experienced and older surgeon, and he's someone that has adopted the robot and is a big proponent of it. And so I guess I look to him as someone that believes in this technique and also has adapted to it during this time period. I'm not sure if that directly addresses your question. We didn't look to see how many years of experience they had or whether a resident was directly involved in this case.
We'll go to Dr. Smith and then Dr. Toffi.
Steve Smith, Gainesville, Florida, nice paper. In the real world, OR time equals money. So have you done a cost comparison of the different techniques? If the results are essentially equivalent, why spend more money?
Exactly.
I think that is definitely a ongoing struggle with the robotic technique. If we're going to have these same outcomes, why spend more money? As we pointed out, we don't know if these were more difficult cases, ones that, if you performed laparoscopically might have had increased difficulty or, technical issues. But I definitely see your point and think that's an ongoing struggle with robotic surgery and trying to argue with coverage and increasing its use.
Dr. Toffi, really short question.
Shervin Toffi, Beverly Hills, California. Can you please explain to me the rationale for excluding women in this study? We have almost no data supporting what we should be doing in women exclusively, especially in these large databases. This would have been a nice opportunity. And you include robotic surgery, which was only 1% of your population, but not women, where in the VA are greater than 1% of your population.
Thank you for that question. Clearly that was a choice that you point out. The women in the VA population are a very small percentage, and I think it was 1% or close to that, which led to our decision to exclude it. But I will have to go back and look at that before we publish and reconsider. And
Actually, it's an opportunity for another paper, because even 1%, they might be quite high. So thank you very much.
Okay, thank you.
Our next paper is Breast Center Accreditation Provides Improved Access to Breast Reconstruction, and Dr. Nicholson will be our presenter.
That'd be great.
Sorry, your 7:15 was 15 minutes.
Yes, I know.
Sorry.
Good morning.
Good morning. Good morning, everybody. I'd like to thank the Western Surgical Association for giving me the opportunity to present this morning. I will be presenting on behalf of the National Accreditation Program for Breast Centers Data Working Group. Today I will be discussing how the NAPBC accreditation has improved access to breast reconstruction. I have no disclosures. In 2011, the National Accreditation Program for Breast Centers, also known as NAPBC, enacted a standard requiring centers to provide a referral to a reconstructive surgeon for eligible breast cancer patients undergoing mastectomy. The purpose of this study was to examine if this standard impacted reconstruction rates at NAPBC sites compared to non-NAPBC sites. We used the National Cancer Database, also known as NCDB, to look at sites that were flagged as NAPBC accredited sites versus non-accredited sites. Of note, patients that were included in the mastectomy group were patients that had a unilateral or bilateral mastectomy, modified radical or radical mastectomy, We also looked at patients that had reconstruction versus without reconstruction. And of note, patients that had nipple-sparing mastectomy were included in the mastectomy with reconstruction group. We looked at the following variables, overall looking at different patient demographics, and as well as different facility characteristics. We compared reconstruction rates at NAPBC sites versus non-NAPBC sites. We then evaluated reconstruction rates over time and looked at what reconstruction rates were before and after NAPBC accreditation. Finally, we examined reconstruction rates stratified by patient demographics and facility factors. First, we looked at demographics and compared these demographics amongst non-NAPBC accredited sites versus NAPBC accredited sites. We found that the mean age was very similar amongst non-NAPBC versus NAPBC accredited sites. We also found that for NAPBC sites, there was an increase in percentage of Black and Hispanic patients. We also found for NAPBC sites, most patients did have insurance, most of which were private or Medicaid insurance. We also saw that for NAPBC sites, a majority of these sites were high volume facilities. And finally, we noticed that there was an increase in the number of community-based facilities that were NAPBC accredited. We next looked at the impact of NAPBC accreditation on breast reconstruction rates. This graph here shows the unadjusted reconstruction rates for 3 years prior to NAPBC accreditation and 3 years after NAPBC accreditation for centers accredited in 2010 to 2016. We found that there were significant differences in reconstruction rates before and after NAPBC accreditation for centers accredited in 2010 to 2015, but not for centers accredited in 2016. There was no data for after 2017 to evaluate centers accredited in 2017, therefore we stopped at 2016. So overall, we saw that there was a rise in reconstructive rates from 2010 to 2013, and as you can see, there's a drop in 2014 that we were not able to explain. We next did a multivariate analysis, adjusting for patient socioeconomic and facility factors, and we found that NAPBC accreditation was associated with a 1.33 increase odds of undergoing reconstruction compared to not undergoing at NAPBC accredited sites. We completed this analysis for before and after NAPBC accreditation, looking at years 2004 to 2008, and then more recent years 2016 to 2017. Next, we looked at trends associated by patient race and ethnicity. We found that overall for years 2009 to 2017, there were increased rates in reconstruction for all races. This graph here specifically looks at 2017. We found that Hispanics now have reconstruction rates slightly greater than whites. African Americans and Asian Pacific Islanders, however, still have a lower likelihood of undergoing reconstruction compared to whites, and this likelihood has not changed since NAPBC has started. Oops. Then we looked at the Medicaid expansion. The Patient Protection and Affordable Care Act Medicaid expansion was implemented in 2014. And our data showed that there was an increase in reconstruction at NAPBC facilities over this time period. And this increase persisted after adjusting for patient and facility factors. The limitations of our study: this was an observational study. Our data shows association, but not necessarily causation. Also, our data only comprises patients through 2017 and cannot account for more recent trends. And finally, the NAPBC standard requires centers to provide a referral to a reconstructive surgeon, but there was no way for us to confirm if these centers indeed did get these referrals, so we can only infer that these increases in reconstruction rates were due to the implementation of this standard. In conclusion, NAPBC accreditation is associated with increased rates of breast reconstruction for patients that are typically considered to have low access to reconstruction, all patient races, and we saw a significant increase for specifically Hispanic patients. However, we did find that disparities still exist for African American and Asian patients. This may be due to access of care, it may be due to cultural differences, or both of those. We also found that there was an increase in breast reconstruction in 2014 when Medicaid expansion was implemented. And finally, we found that there was an increase in patients treated at community-based facilities. Thank you so much. I will take questions. Thank you.
Since we started a little early, we will have some time for questions. So do we have any questions from the floor? Dr. Johnson's getting up. Dr. Hansen. Dr. Johnson?
Nathalie Johnson, Portland, Oregon. Thank you. That was very well presented, and I think timely, because a lot of institutions now are looking at what the value of being accredited is. So from your data, what would you tell an administrator that the value of NAPBC accreditation would be?
Thank you so much for your question. I think the main point of this study was that just showing that overall for patients that are typically associated with low access to care, so patients that are within the minority population, patients that are typically at community-based programs, accreditation seemed to have increased the number of breast reconstruction rates at these facilities. So I do believe one of the goals of NAPBC was to improve access to care, and this study showed that this was done for at least up until 2017. So I believe that that's overall the mission for us here for medicine, and this study shows that.
Great. Dr. Hansen.
Great. Nora Hansen from Northwestern. Excellent presentation. Why did you think you saw a drop in 2016? Do you have any idea of why that would be? And then did you see a big difference between those in the academic institutions versus the community community practice-based programs with the increase? I know there's a higher number of community-based programs in the NAPBC, which I think they use it more, I think, as a marketing tool, to highlight their program. So I think it is important for them. And then the other question is, do you think that there was a difference in terms of being able to pay for the reconstruction? Was there a difference in the financial component? Because even though they have insurance, sometimes the co-pays are quite high, and some of the patients just can't afford the reconstruction. But excellent talk.
Thank you so much, Dr. Hansen. For your first question, after reviewing the data and looking, and we saw that decrease, I believe it was in 2014, and just kind of thinking through as to why, that was one of our top questions too, like why did we see this change? I'm not exactly sure why there was a decrease in that specific year when looking at different standards that were implemented or anything, so we did not find anything that actually caused that. For your next question, jumping to your last question, for pay for reconstruction, that is a great point as well. We did not take that into account for this study, but I think that would be something that we should definitely look into in the future. I'm trying to remember the second one. For the second one, Dr. Yes, thank you. Thank you. So community-based versus academic, that was also something that was very interesting. I think, as you mentioned, we did see that there was an increase overall for the number of sites that were accredited by NAPBC. And I do think you did make a key point that it might have been for marketing purposes, and that's something that we should take into consideration, but also just a point that we made for the improvement in access to care, that now those sites typically have an increase in breast reconstruction.
Okay, and we'll take one more short question.
Very short. Sanjay Joseph, Las Vegas. The mandate to have at least a referral for reconstruction, it seems as
would be the largest driver to create this? Should we go the other direction? Instead of talking about an NABP certification, should we just make this a mandatory part of mastectomy evaluation for all patients?
Yes, I completely agree. Thank you.
All right, thank you very much.
Thank you so much.
Because I started us early, we had a little extra time, which we've now made up and used, so that's good. Our next presentation is another quick shot. These are supposed to be 5 minutes of the person doing the talk, and then 5 minutes open for discussion. This is going to be a virtual presentation, and then, so I think, are we ready to go with that? All right.
We have nothing to disclose. Parathyroid carcinoma is a rare disease, and most individual institutions have too few cases to assess research questions on this disease, and thus large databases are one of the best sources of information. The last NCDB review, published in 2015, assessed patients from 1985 to 2006. There were 733 patients in the study, and decreased survival was associated with older age, larger tumor size, and male sex. Overall survival at 5 and 10 years was 82.3% and 66% respectively. Our goal was to provide an update on prognostic factors, outcomes, and overall survival from the current NCDB database, as there has been over a decade since the last review. This was a retrospective review of the NCDB from years 2004 to 2017. Patient factors examined were age, gender, race, insurance type, income, Charleston Comorbidity Index, facility type, and facility location. Treatment and pathologic variables included extent of surgery, radiation and chemotherapy, tumor size, margin status, lymph node status, and metastatic disease. Univariable and multivariable Cox proportional hazard survival analyses were performed, as well as Kaplan-Meier survival curves. Here are the results of our patient demographics and their pathologies. There were 650 patients with a mean age of 57 years. 67% of patients were white, 16% were black, 9% Hispanic, and 3% Asian Pacific Islander. Average tumor size was 3 centimeters. Less than 10% had positive nodes, and less than 1% of patients had distant metastases. These are the results of overall treatments of patients. Regarding surgery, 2% of patients had no surgery. 53% had incomplete tumor removal, 38% had complete tumor removal, and 5.8% had radical surgery. Just over half of patients had negative margins, and a quarter of patients had positive margins. 15.7% had radiation treatment, and less than 1% received chemotherapy. This is a Kaplan-Meier survival curve showing older age predictive of worse survival. We also saw this in our multivariable analysis. Here's another Kaplan-Meier survival curve showing that tumor size is also predictive of shorter survival. Patients with tumors greater than 4 centimeters have shorter survival than those with smaller tumors. These curves demonstrate the difference in overall survival of patients with and without metastases. Those without metastases live longer than those with metastases. We examined whether the extent of surgery affects overall survival in parathyroid cancer. We found that patients with any type of surgery had improved survival over patients with no surgery, but the extent of surgery had no bearing on overall survival. In this analysis, radiation and chemotherapy did not affect survival. It appeared that chemotherapy might on the univariable analysis, but showed no difference in survival on the multivariable analysis, and radiation treatments did not affect survival. We finally examined the differences in overall 5-year and 10-year survival between the last NCDB review and the current data, and found that although there was a trend of improved survival, this was not statistically significant. There are limitations to this study. Parathyroid cancer can be difficult to diagnose, and cases reported may not be of the same pathologies between different institutions. In the NCDB, there is no data on disease-specific survival, which would have been important and interesting to assess. There's also no data in the NCDB on calcium levels, quality of life, recurrence data, or data on reoperations. In conclusion, parathyroid carcinoma survival rates have remained stable over the last 4 decades. Older age and larger tumor size remain predictive of worse survival. Use of radiation or chemotherapy are not associated with increased survival. And patients treated surgically and those without metastases have improved survival. Thank you for your attention.
Okay, so this is with our hybrid meeting, and we so can you see us? We can see 14 copies of you. It looks good, though. It all looks good. So any questions from the floor?
Yes, Terry Moore from LSU. I enjoyed your study. It's great work. I'm intrigued by your results. I understand the limitations of these cancer outcomes database, administrative databases. We're always taught or have been told over the years to do a unilateral thyroid lobectomy and to do lymphadenectomies for patients with clinically, sonographically, or cytologically positive nodes. I'm intrigued that with the limitations of your data set, you were not able to show that extent of surgery affects survival and really not addition of chemotherapy or radiation therapy. The strongest predictor of survival, if I understood your data, was the presence or absence of metastases. So should this change our recommendations for our extent of surgery for parathyroid carcinoma? We often have to take the thyroid lobe because of the infiltrative nature of these tumors. But it's a very fascinating disease. It's one that we see so rarely that it's difficult to come up with a firm evidence-based treatment paradigm. Thank you.
Yeah, thank you for your question. It was intriguing to us as well that the extent of surgery did not affect overall survival, and that radical surgery, which would mean taking of at least part of the thyroid, did not seem to affect survival outcomes. That's just survival outcomes. We don't have data on how high calcium levels affected patients based on the extent of surgery. So I don't think I'd be ready based on this to change practice, but I think this is interesting data. We need to continue to assess whether extent of surgery does make a difference.
Okay. Other questions from the floor? Or anybody virtually? I don't know if we have a way for virtual people to put questions in a chat box or anything. Probably not. I'm very interested in parathyroid carcinoma, mostly because on the board exams one time this past year, there were like more questions about parathyroid carcinoma than there were patients in the United States and the world with the disease. But I have the same question. You know, the operation is quite radical. It is interesting to me because it did make it onto the board exam, but I don't think, let's just have a show of hands in the room. Who's ever treated a patient with a parathyroid carcinoma? Okay, and if you're an endocrine surgeon, put your hand down. Okay, like one, yeah, so it's two, Amanda's very rare. So I really wish we could have the questions on the oral board exam be like not such crazy ones. Do we have one more question?
Julian Beaner, Rochester. So thank you very much for your nice presentation. Similar to the pediatric oncology groups, it's very hard, it seems, to make any progress on rare cancers. is there a place for, rather than having a database that is so generic, to have a registry of interested groups to see if that way can make any progress for those patients?
Yeah, I think that would be an excellent suggestion. Mayo is starting to do some studies on parathyroid cancer, so I think it might be a good idea for other institutions to join Mayo and see collectively what answers we can come up with for disease.
All right. Thank you very much. We're going to go ahead and move on to the paper session. Thanks for joining us virtually. All right, so now we're moving on to the paper sessions. Now, I want to remind people that for the oral presentations, these are 20 minutes total. We have to stay on time. We're giving you all of a 10-minute break in between some things later on, so just want to make sure of that. So a couple things to remember: 10 minutes presentation, 3 minutes invited discussion, and then 2 minutes reply from the closing author, another 5 minutes for the floor discussion. I think one of the things most of us love about this organization is the floor discussion. So if the discussant and the presenter want to shorten up their parts, then we have more time for questions from the floor. I also want to remind folks that a member has to close, so if the presenter's not the member, we'll hopefully have somebody, the member, stand up to do the closing. And I'll try to give you the sign if you're going over and to get us moved on. So I think that's it. So our first paper is Factors Predicting Mortality in Patients with Early Onset Colorectal Cancer Undergoing Surgery, an Analysis of the National Cancer Database. The presenter is Mohammed Kiram from the University of Arizona. Dr. Kiram?
Just a quick reminder for discussants, please state your name and your institution clearly so that we can record it up here. Thanks.
Good morning, everyone. I would like to thank the Western Surgical Association Program Committee for providing me the opportunity to present our work. We have nothing to disclose. Colorectal cancer is the third most common cancer diagnosed among males and females in the United States. Although the overall incidence of the colorectal cancers has experienced a downward trend in recent years, but the incidence of the early onset colorectal cancers has steadily increased by approximately 2% and mortality by 1.3% every year. A previous study conducted by our group has shown that there is a decrease of overall incidence of the colorectal cancer, but there is a significant increase of early onset colorectal cancers. Moreover, studies have shown that the patient with early onset colorectal cancer usually present at the later stage of the disease and symptomatic at the time of diagnosis. I'm sorry for that. I don't know what's happened here on the screen. These distinguishing characteristics suggest that the patient with early onset colorectal cancer may exhibit unique etiological feature and different prognosis compared to the late onset colorectal cancer patients. Recent studies have also shown that there is increased mortality in patients with early onset colorectal cancer on unadjusted analysis, which is associated with being diagnosed at the later stage of the disease. Although the robust scientific and epidemiological studies have pointed out multiple factors linked to early onset colorectal cancer, including genetic predisposition, environmental factors, and certain comorbidities, our knowledge of factors that could be associated with increased mortality following surgical intervention in early onset colorectal cancer patients is far from complete. So the aim of our study is to explore the social, ethnic, racial, and disease-related factors that could be predictive of the post-operative mortality among patients diagnosed with early onset colorectal cancers. We hypothesize that certain social, ethnic, racial, and disease-related factors are associated with increased mortality in early onset colorectal patients post-operatively. For this, we perform a 14-year analysis of National Cancer Database. We include all patients with less than 58-year age diagnosed with colorectal cancer and who underwent surgical interventions. We exclude patients who are not surgically managed. To explore the tumor characteristics of our patient, we use ICD-10 diagnosis codes. We perform following statistical analysis. We perform multivariate linear regression analysis to control for multiple confounding variables. Our outcome of studies is 90-day mortality after surgical intervention, predictive factors independently associated with 90-day mortality. Overall, more than 145,000 patients with early onset colorectal cancer were identified. Among those, 85% of the patients underwent surgical intervention. The mean age of our study population is 43. 52% of the patients were male, 86% of patients were non-Hispanic, 78% were white, and more than 14% of patients were black. Most of the patients of our study population were in middle income quartile, were living in metro counties, doesn't have any comorbidities, or were primarily insured. Almost 70% of the patients were diagnosed with colon cancer, and 30% of the patients were diagnosed with rectal cancers. The most common histological pattern in our study population is adenocarcinoma, followed by mucinous and signature cell. Most of the patients have a more moderately differentiated disease. 95% of the patients have invasive neoplasm at the time of diagnosis. 43% of the patients have lymph node involvement, and 16% of the patients had lymphovascular invasion at the time of diagnosis. Regarding tumor staging, the most common pattern in our study population is stage 3, followed by stage 2, stage 1, stage 4, and stage 0. 90-day mortality after surgical intervention in our study population is 1.3%. On multivariate regression analysis, after confounding for multiple confounding variables, we found that the increasing age is associated with increased 90-day mortality. Non-Hispanic ethnicity is also associated with increased mortality. Black race is also associated with increased mortality, but it's not statistically significant. Household income of lesser than $62,000 were also associated with increased mortality. Or having comorbidities is also associated with increased mortality. Non-insured status is associated with increased mortality as well as the grade of neoplasm. And stage 4 disease is also associated with increased postoperative mortality in colorectal patients. In conclusion, ethnic and socioeconomic disparities in postoperative mortality exist among patients with early onset colorectal cancer patients. In terms of race, black race tends to have higher mortality, but not statistically significant. Highlighting those factors would be incredibly advantageous in allowing the medical community to provide preventive screening and education for these targeted population. Thank you.
Thank you very much. This paper will be discussed by Dr. Saju Joseph, and you can do it from the floor. Thank you.
Thank you. Saju Joseph, Toro, University of Nevada. Thank you very much for allowing me to discuss this paper, and thank you for sending me a copy of it early so I could review it. Two quick questions. One was, could you postulate, I recognize that this is a database study, so there is confounding in there, why there was a difference in the non-Hispanic population for terms of the mortality rate based on the other factors? And then second question is, in the lower socioeconomic group with the higher mortality rate, was there a difference in in-hospital mortality or post-acute care? In other studies, your group and others have published that, a lot of the mortality that comes from that lower income group is not in the hospital, but the lack of access and the care that is required after discharge from the facility. Thank you.
Okay, and Dr. Fonsom is going to be closing, or he's going to be making the remarks to answer those questions.
So thank you, Dr. Joseph, for actually your timely and critical review of our manuscript and also your insightful comments and questions. So in our studies, we actually showed the overall incidence of colorectal cancer in the last several decades heading down, but significant increase in younger patients. So, and we actually saw mortality of 1.3% in younger patients, and this clearly due to recent advancements in treatment modalities. So in addressing your question on, and within the Hispanic group, found a higher, the non-Hispanic group, we found 90%, 90-day mortality to be higher. So in addressing that, the NCDB database actually look at, so that's ethnicity, which is completely different from race, so two different things. But we actually look at the different races under the non-Hispanic group, and we saw that African American patients had a 1.4% higher chance of getting developing colorectal cancer compared to non-Hispanic whites, which was 1.3, and even the Asian population had a slightly lower chance of developing colorectal cancer. So, but overall, the mortality is low. These are normally healthy, very healthy individuals, as you can see in their comorbidities. 87% of them had no comorbidities at all. In addressing your second question, and in the lower socioeconomic group, did we look at the in-hospital mortality? So we did look at a 30-day mortality, which actually doesn't really capture the in-hospital mortality very well, and we were focusing more on the 90-day mortality, which was actually a longer term, and so I actually agree with your comment that that this group of patients that are in the lower socioeconomic group, they tend to have significant problems in taking their medications and following up after surgery. But we also have to recognize that most of them actually present with more advanced disease due to delay in presentation, and so their inpatient mortality might be slightly affected, even though we couldn't capture that data. But more importantly, I think their presentation with more advanced disease and lack of education and stuff like that might actually impact that more. And I'll take any questions.
Okay, we'll go ahead and have other questions. Dr. Johnson?
Nathalie Johnson, Portland, Oregon. And I have a question and maybe a philosophical point. And that is, in breast cancer, we do so much genetic testing, but I don't see that really discussed very much in the colorectal world. And in this particular paper, we're talking about young people under 50, and I really think that's a point that we should drive home. And one of the things that we'll do better at in preventing death in younger people from colorectal cancer is screening. And one of the things that we found in breast cancer as we've done larger panels is that a lot of the genetic mutations we find in breast are actually related to colon cancer. CHEK2 and MUTH were some of the highest things we found, and MUTH is actually more associated with colon than it is breast, at least currently. So we're learning a lot, and so my question, I guess, would be, was there any information about what % of these people actually had genetic testing? And two, would you comment on my thoughts around doing a better job of genetic testing in the colorectal world? Thanks.
I'm actually going to comment on that. I think that's an amazing question, and in our previous work, we've actually looked extensively on, so we see this increase in colorectal cancer in younger patients. We think that is multifactorial, and part of that in that mix, we think that the tumor biology is also changing. And so in our previous work, we've actually shown that the tumor biology of younger patients, there's certain genes that are overexpressed in younger patients compared to older patients. We also showed that this overexpression of these genes actually impact mortality down the road. And so yes, in colorectal, we don't have a lot of gene panels like they have in breast to actually assess patients, but I think it's a great idea, and that's actually the direction we're heading, because that's also important for personalized treatment. So why would you treat a patient who has a certain genetic predisposition with the same chemotherapy regimen when their response to that chemotherapy regimen is completely off? So personalized and genetic testing for younger, especially for younger patients, is actually important. Now, we think there are other factors in addition to that. We think these are normally really healthy people. Like you can see 87% of them are the people who go to the gym, they're healthy. We also think that the microbiome also plays a role in this. We also think that, other pathogens like HPV that normally we look at it in squamous cell carcinoma, we've actually shown that 100 plus genes of HPV, maybe one of them is involved in, especially in rectal cancer. What was your first comment?
Dr. Fonsom, you'll have to make shorter answers. But you got people stacked up. So,
Hey,
Dr. Russell?
Dr. Fonsom?
Val, why don't you come
Val,
up?
come up at the front. You're a closer. You're a presenter. It's too hard to, you're doing that dance beautifully back and forth with the microphone, but
Come up
coming
front,
up
and
here with your colleague.
Listen to the question, then we'll ask Dr. Russell to give, and then we have 2 more questions. So
Okay,
quick,
thank
short
you.
questions, short answers.
Thank you. John Russell, University of New Mexico, Albuquerque. So in terms of looking at these outcomes, it strikes me that there are perhaps 3 factors, and there may be an interplay of them. One is going to be stage of diagnosis, which relates to access to screening as an example, right? Second would be differences in access to subsequent care, whether they got radiation, chemotherapy, or a combination thereof. And 3, different tumor biology, which you've previously discussed in terms of your prior studies. How do you sort these out? What does this data tell you about the relative contributions of those 3 factors?
Right. So I'm going to try to make this short. So I think you're right. I think it's a combination of those 3 things. I think access plays a significant role because especially younger patients, and education too, because especially younger patients typically present with more advanced disease. So delay in presentation is also an issue. So not only access, but also education. So it's just like the same story you hear for every young patient in their 20s or 30s or 40s who show up with advanced disease. They've actually been seen by multiple physicians, multiple. It's just the same story. So so in teasing out this data, from this database, it would not be easy to tease, to actually separate which ones present as a delay in presentation, but I can tell you that they all present with more advanced disease. If you look at it, it's mostly stage 3 and stage 4 disease. If you put that together, it's more advanced. Lower socioeconomic people, beyond going out of the hospital and after being treated, that actually is important information, because that means that we have to do a better job of educating patients as they go out of the hospital. Especially, we got to recognize the fact that not everybody have the same, so the type of discharge, instructions I give somebody who's educated and a higher income bracket should be a little bit tailored differently to somebody who does not have that same capability. And tumor biology, I probably talked about that already. Yeah.
Okay, we have time. We do have time for a couple more comments, because I think we've gotten until 8
Very
or
nicely
5.
presented, important work, and congratulations on this. I think to follow up on Dr. Johnson's important point, genetic testing for colorectal cancer is actually not approved outside of patients that are younger than 50, and it's really only approved in the metastatic setting for next generation sequencing, and which is an important thing, because although it is approved, it is not commonly done at many institutions. And we have multiple targetable agents, mutations, et cetera. So I wonder, do you think with this increase in younger patients with colon cancer, will we move towards sequencing these patients outside of the metastatic setting?
So I think that's actually a direction where most colorectal surgeons are heading to, especially since we're looking at this other work that shows that response to chemotherapy and radiation might be different for these patients that present in an early stage. If you actually take into consideration that they present with a higher stage disease, still their response to chemotherapy, if you do a propensity matching looking at older patients with higher stage disease and younger patients with higher stage disease, their response might be different. So yes, sequencing these patients with younger patients, and so that personalized medicine can actually be done, yes.
And our last question?
John Corson from Albuquerque. I think this was a good paper, but it confused me a little bit. So can you explain a little bit about these 90-day mortalities? Are these people dying of surgical complications, or are these people dying of their disease within 90 days? Can you clarify why they're dying?
It's a good question. So 30-day mortality actually is looked at as perioperative mortality, so 30 days. 90-day mortality is actually looked at as like long-term mortality, believe it or not, so anything beyond 90 days. So within 30 days, it could be considered complication from surgery. But beyond 90 days, beyond 30 days, it's not considered complication from surgery. This is more from disease progression, or maybe it was just a significantly advanced disease. Now, you can even look beyond 90 days, and I bet you, so if you want to look beyond, you're going to look at 3-year mortality or 5-year mortality. But 90 days kind of give you an idea of long-term, which is not perioperative. Yes.
All right.
Yes.
Thank you very much.
All right.
Great job. All right, so I'm finally reading the directions that were left for me, but what we will do is for the papers, if the person presenting is not the member, then have the member come up to close from the podium. So once we get done. So the next paper is delayed adjuvant endocrine therapy is associated with decreased recurrence-free survival following a neoadjuvant chemotherapy for breast cancer, and our presenter is Dr. Sutton.
Good morning, and thank you to the Western Surgical Association and our moderators for the opportunity to present this work. We have no disclosures. Adjuvant endocrine therapy is standard of care for patients with hormone receptor-positive breast cancer. Additionally, adjuvant radiation therapy is standard for patients receiving breast-conserving therapy or receiving mastectomy with large tumors or positive axillary nodes. The optimal timing of adjuvant endocrine therapy relative to radiotherapy is unclear, however. There is a theoretical reason to delay endocrine therapy, in that radiation therapy works best on rapidly dividing cells, which endocrine therapy slows. While there are no clinical data showing worse local regional recurrence rates following, when endocrine therapy is started concurrently with radiotherapy, there are data showing that this may increase late radiation-associated morbidity, such as skin or pulmonary fibrosis, without affecting distant recurrence rates. Notably, all of these data are retrospective, but for this reason, most providers lean toward later initiation of endocrine therapy for most patients receiving radiation. Oops, excuse me. How do I go back?
You got to right-click and get
Thank you. However, this question is completely unstudied in patients undergoing neoadjuvant chemotherapy, who are at significantly higher risk of distant recurrence in the cohort of hormone receptor-positive disease as a whole. It is possible that patients may benefit from early systemic endocrine therapy if they require neoadjuvant therapy because they have, in general, more aggressive disease. rather than waiting 3 to 4 months postoperatively until the radiotherapy is completed. Therefore, our objective was to investigate this question in the high-risk population. To that end, we queried our multi-institutional cancer registry for women with non-metastatic breast cancer diagnosed from 2011 to 2017, who underwent neoadjuvant chemotherapy, resection, and adjuvant radiation. The residual cancer burden score, which scales linearly with recurrence risk following neoadjuvant chemotherapy, was calculated for all patients during the standard of care pathologic evaluation of their specimens. Additionally, we calculated the interval from surgery to endocrine therapy, or ISET, for all patients in weeks. Finally, we also captured and graded late radiation morbidity. We evaluated recurrence-free survival, overall survival, and radiation complication-free survival, all measured from the date of surgery, utilizing Kaplan-Meier analysis and Cox proportional hazards modeling. Multivariable analysis was performed by including all variables with a univariable p-value less than 0.2 in initial models, followed by single backwards elimination. ISET was analyzed both as a continuous variable and by using recursive partitioning to identify the ISET cutoff point associated with the greatest disparity in oncologic outcomes, thereby creating a dichotomous variable. 179 patients were identified, with 38% starting adjuvant endocrine therapy before or during radiotherapy. This group had lower HER2 positivity, higher median RCB score, and higher letrozole use, but was otherwise similar to patients starting endocrine therapy after radiotherapy. Notably, the median ISET was 5 weeks in patients starting endocrine therapy before or during radiotherapy, and 17 weeks for those starting after. Median postoperative follow-up for the cohort was 49 months. Utilizing recursive partitioning, 14 weeks was identified as the ISET cutoff point associated with the greatest disparity in oncologic outcomes. At the time of analysis, 27 recurrences were noted, with 24 being as distant metastases. A significant disparity in 5-year recurrence-free survival was noted between patients with ISET greater than 14 weeks and an ISET of 14 weeks or less, at 90% versus 74%. At the time of analysis, there were 25 deaths, most occurring after the 5-year time mark, while a numeric difference in 5-year overall survival was noted between ISET groups at 95 and 86%. This difference was not significant. On univariable analysis, clinical stage 3 disease, higher RCB score, and ISET greater than 14 weeks were each associated with worse recurrence-free survival, while clinical stage 3 disease and higher RCB score were associated with worse overall survival. Notably, ISET was not significantly associated with overall survival. On multivariable analysis, ISET greater than 14 weeks was an independent predictor of worse recurrence-free survival, along with higher RCB score. Higher RCB score was also the only independent predictor of overall survival in the cohort. Importantly, these results did not change when ISET was analyzed as either a continuous variable or as the dichotomous variable using the 14-week cutoff point. There were 59 instances of late radiation-associated morbidity, almost all of which were skin and soft tissue, and 3/4 of which were grade 1. Both higher RCB score and endocrine therapy initiation before or during radiotherapy were associated with higher hazard of radiation morbidity. However, only RCB score remains significantly associated on multivariable analysis with this outcome. In this analysis, RCB score likely served as a surrogate for either higher radiation dose, wider fields, or more extensive resections, which likely predisposed to radiation morbidity. Our study is limited by its retrospective nature. Additionally, due to the rarity of this patient population, we were underpowered to look for differences in overall survival, despite this study taking place at a high-volume breast cancer center. An additional limitation is the absence of radiation dosing and treatment field information for our analysis of radiation morbidity. Finally, we cannot rule out selection bias in ISET timing that could be influencing the observed findings. However, the lower median RCB score and the higher proportion of HER2 positivity in this cohort in patients starting endocrine therapy after radiotherapy, I should say, suggest against the possibility that these patients had inherently worse prognosis. In conclusion, a longer ISET is associated with worse recurrence-free survival in patients with hormone receptor-positive breast cancer, who have undergone neoadjuvant chemotherapy and adjuvant radiation. This population is high risk for recurrence and may benefit from early systemic treatment of micrometastatic disease. The baseline prognostic differences of this cohort may also explain why our study came to different conclusions than prior studies investigating ISET in all patients with hormone receptor positive disease. Regarding radiation morbidity, the consent randomized trial is currently enrolling and aims to provide high-quality data on whether the timing of endocrine therapy is associated with this outcome. While this will bring valuable data to this discussion, we feel that prospective study of endocrine timing and oncologic outcomes, specifically in patients who are at high risk for distant recurrence, is warranted in light of the present findings. Until higher quality data become available, we urge caution in delaying adjuvant endocrine therapy in high-risk patients. I'd like to thank my mentors, Drs. Johnson and Garreau, for their support, and we will happily take questions.
Okay, thank you very much. And Dr. Nora Hansen is discussing this paper. And Dr. Johnson, why don't you make your way up here while she's giving her discussion?
Great. Thank you, Madam President. I would like to thank the association for the privilege of discussing this paper and to the authors for getting me the manuscript in timely fashion. Dr. Sutton, congratulations on an excellent presentation and a well-written paper. The dilemma of the timing of initiation of endocrine therapy is not a new one, and there is evidence to show that there's no difference in overall survival if endocrine therapy is initiated within 1 to 2 years. However, those studies previously have not really addressed the neoadjuvant patient. Presumably, patients undergoing neoadjuvant therapy have more aggressive disease, so earlier intervention impacting relapse-free survival is understandable. But why would it not have an impact on overall survival in your study? I'm interested in your thoughts. I also have several other questions for the authors. Why was 14 weeks chosen for the dichotomizing variable analysis while the median ISET for the study was 12 weeks? What were the reasons for the delay in initiating endocrine therapy? And did you see any difference in your data for patients undergoing breast conservation versus a mastectomy? And was the ISET different for these two groups? And then my last question is, as the duration of radiation therapy has been decreasing, did you see a decrease in the ISET over the accrual period with the onset of new RT protocols? And was there a difference between the breast conservation and mastectomy? Again, congratulations on a well-presented paper, and I look forward to your discussion.
She'll ask him again.
All right, thank you so much for your questions, Thomas. Thank you for well done presentation and just your work. So I'll just start out by saying that what happened was we looked at this data set. Really initially, Dr. Garreau was looking for complications with timing of surgery after neoadjuvant chemotherapy. And then we noticed that there was an oncologic difference in patients where the timing was longer between the end of chemotherapy and surgery. And in that data set, the hormone receptor positive patients actually had a worse outcome, and we tried to figure out why that was. And then we tumbled to the onset of neoadjuvant endocrine therapy. So I think it is really a select group. You're choosing high-risk patients coming off of chemotherapy, and then we wait several weeks, and then we do surgery, and then we wait for them to finish radiation. So actually, many of the patients are on no systemic therapy for 4 or 5 months between the time that they finish chemo and the time that we start endocrine therapy if we do it in the traditional fashion. So I think what we're seeing is this, the question of a higher group, higher risk patient group starting neoadjuvant endocrine therapy earlier. And I think the point to take home is that the group that started in neoadjuvant endocrine therapy earlier, or less than 14 weeks, were patients that had higher RCB scores, which means more residual disease, and yet they had a better outcome. So I'm not sure I got all your questions, but to answer the first one was that why did we not see an impact in overall survival? And I think it's based on the patient numbers and also maybe length of time that we followed. If we look at this data again in another few years, I think we will see a difference in overall survival because there's such a big difference in recurrence-free survival now. So I think that timing. In terms of choosing the interval and looking at 14 weeks, I think I'll let Thomas answer that question because he's the statistical guru, and so he figured out that that was a good cutoff point. Why didn't you answer that, Thomas?
Sure. So we pre-specified our statistical methods a priori prior to looking at our doing the analysis, and so we decided to do it in two ways. One was to analyze ISID, as I mentioned, as a continuous variable, which gave the same results that we presented here. But then we also used a technique called recursive partitioning, which is when you're doing a somewhat exploratory analysis where you don't necessarily have any baseline for where you're, for a cutoff point in an outcome like that. Recursive partitioning allows you to essentially identify the cutoff point where the greatest disparity is, in this case, recurrence-free survival between the patients below and above that cutoff point. And so again, we didn't specify where that would be before we started the analysis, but that's what that technique landed us at, was 14 weeks.
Thank you. And then I think the take-home point is that this is a group of patients that would benefit oncologically from starting endocrine therapy post-operatively as opposed to waiting until after they complete radiation therapy. So to me, that's a clinically actionable finding. So thank you. Did I get your questions? Okay, thank you.
Dr. Godellis.
Hi, Dean Godellis, Loyola, Chicago. Two comments, really. So I think that this is very important because not only are more people getting chemotherapy, but at least at our institution, almost everyone is getting radiation, even post-mastectomy. And so I think answering these questions, or this question, is really important about when to start neoadjuvant or endocrine therapy. But it gets me to another comment, which is in your slides you talked about a prospective study, and actually the first several papers have talked about how we need prospective data. And just to the residents and fellows here, it's hard for us older people to do that, but I mean, you guys talk about that in your slides all the time, and yet we never actually do it. And so just a comment to kind of, I know it's not easy, but take this one step further and look towards doing some of this stuff prospective. Thank you.
Thank you. And I think that reminded me of one of your questions, was there a difference between breast conservation and mastectomy? And the answer was that no, I think it was the timing of radiation. And so patients that had mastectomy with radiation also had this delayed onset of endocrine therapy. And I think to just make a comment, I think that we learn a lot from retrospective studies like this. You know, we collected the data prospectively in a registry, but then looking at it, we're learning something. So I don't think that it's not, retrospective scope can be clear sometimes too, I guess is what I want to say.
All right, Dr. Yao, and then Dr. Winchester.
So there have been, a number of studies looking at the timing of surgery and adjuvant therapy and impact on overall outcome. And I just worry sometimes that when we look at this retrospectively, there is so much selection bias. There is so many confounders that we're not accounting for. And we tend to partition off these time intervals into time from surgery to radiation, surgery to chemo, and it's such a short time period when you look at the whole time period of treatment, and we should be backing it up to neoadjuvant therapy. Were there any delays in the neoadjuvant therapy? Did that have any impact? What about the time that they got their mammogram? What about the time they got the mammogram before the mammogram that diagnosed the breast cancer? There are just so many confounders there that I worry that when we just look at a very small segment of time, we're missing all of those confounders and what impact they're really having on breast cancer overall outcome.
Thank you. And I think I can say that in this study, that's not a factor because we do have quality metrics for all of our patients, and we can go back and pull that data and make a comment to that. So I think that one of the things we learned from looking at our data is exactly what you said. I mean, we were able to see time from diagnosis to start of therapy, time from the end of last chemotherapy to the time of surgery, from the time of surgery to the time of starting endocrine therapy and radiation. We have it all, so we can go back and look at that. And I think that controlling for that, this still really stands out as an important factor. Thank you so much. That was a great question.
And lastly, Dr. Winchester.
Thank you. Enjoyed the presentation, great study. Along those lines, if you look at the data for patients who have endocrine positive breast cancer, only 7 to 9% have complete pathologic response rates. So,
I can't hear you quite so well.
yes, so if you look at patients who are ER/PR positive and have a neoadjuvant endocrine or neoadjuvant chemotherapy, only 7 to 9% of those patients actually have a complete pathological response. So along the lines that Dr. Yaz raised, are we wasting our time for those 3 to 4 months, 6 months of chemotherapy? Should you start counting the clock when they're diagnosed?
I think that's a great point. Thank you.
Right.
There you go. And I think we also have in our data, we have all the genomic testing too, so we actually can tell you how many patients were genomically high risk, and therefore they had chemotherapy. And I want to think that a huge number of these patients were genomically high risk, and therefore that's why the neoadjuvant chemotherapy. Thomas, you got more work to do. Thank you.
Right. Thank you. Our next paper is colorectal liver micrometastases are associated with RAS/TP53 co-mutation and poor prognosis after surgery. The presenter is also a member, Dr. Yun-Chin Chun.
Thank you to the Western Surgical for the privilege of the podium. Marty Atson was president of the Western Surgical in 1985. In 1989, he published an article in the Archives of Surgery where he said, "Someday we will be given the ability to see the micrometastases that are responsible for therapeutic failure." Thanks to work by pioneers like Dr. Atson and others, today the gold standard treatment for metastatic colorectal cancer to the liver is surgical resection and has a 5-year survival of 57%. However, almost half the patients will suffer intrahepatic recurrence. Micrometastases are hypothesized to play an important role in the development of intrahepatic recurrence. Micrometastases are defined as microscopic cancer cells separated from the gross tumor by a rim of non-neoplastic liver parenchyma. They have been identified in 24 to 56% of resected colorectal liver metastases. Prior authors have focused on the distance between the gross tumor and the micrometastasis. Based on this distance, authors have recommended the minimum resection margin to avoid intrahepatic recurrence. Some studies have found that micrometastases occur very close to the main tumor, less than 4 millimeters away, and recommend a 2 millimeter margin. Other studies have found micrometastases a bit farther away, but still within 1 centimeter, and recommend a 1 centimeter margin. What is not well studied is the impact of micrometastasis on survival and their risk factors, particularly somatic gene mutations. Our group has shown the importance of somatic gene mutations in determining outcome after liver resection for metastatic colorectal cancer. In particular, multiple gene mutations in doublet or triplet combinations are critically important. Patients with mutations in both RAS, either KRAS or NRAS, and TP53 have significantly worse 5-year overall survival of 21%, compared with 61% without double mutation. We aimed to determine the prognostic impact of micrometastasis in patients undergoing resection of colorectal liver metastasis and risk factors, especially somatic gene mutations. We prospectively enrolled patients at MD Anderson Cancer Center in the US and University Hospital of Lyon in France. Immediately after the specimen was removed from the patient, specimens were sliced. Depending on the size of the tumor, 3 to 8 specimens were sliced to include the border of the tumor and 2 centimeters of surrounding non-neoplastic liver parenchyma. Specimens were fixed and embedded, stained with H&E, and examined histologically by hepatobiliary pathologists. DNA was extracted from FFPE specimens, and depending on the year of the study, mutations in 50 up to more than 130 genes were analyzed. We performed binary logistic regression for risk factors for micrometastasis and performed multivariable analyses of overall recurrence-free and hepatic recurrence-free survival. We had a total of 140 patients, 84 from MD Anderson and 56 from France. Most patients had primary tumors in the left colon and rectum, node-positive primaries, synchronous liver metastasis. Almost all the patients, 86%, received neoadjuvant chemotherapy before liver resection, including 49% with bevacizumab. Almost a quarter of patients underwent a major hepatectomy. 2/3 of patients had resection of multiple colorectal liver metastasis, and median size of the largest tumor was 2.8 centimeters. 72% had an R0 resection margin, 31% had double mutation in RAS and TP53. 26% of patients had micrometastasis identified in their liver specimens. 5-year overall survival was significantly worse with micrometastasis at 39%, compared with 61% without micrometastasis. Similarly, recurrence-free survival was also shortened with micrometastasis, with 0 5-year survivors without recurrence, compared with 20% without micrometastasis. The difference in survival was especially pronounced for hepatic recurrence-free survival. For patients with micrometastasis, median survival without intrahepatic recurrence was 13 months. In contrast, in patients without micrometastasis, median survival without intrahepatic recurrence was almost 4 times higher at 48 months. On multivariable analysis, predictors of overall survival were node-positive primary, extrahepatic disease, micrometastasis, and double mutation in RAS and TP53. In univariable analysis, micrometastasis but not R1 resection margin was significantly associated with hepatic recurrence-free survival. On binary logistic regression for predictors of micrometastasis, number and size of tumors, bilateral disease, resection margin, and any neoadjuvant chemotherapy were not significantly associated. On univariable analysis, predictors of micrometastasis were age 60 or greater, minor hepatectomy, failure to receive treatment with neoadjuvant bevacizumab, and RAS TP53 mutation. On multivariable analysis, the receipt of preoperative therapy with bevacizumab significantly decreased the risk of micrometastasis. In contrast with RAS TP53 double mutation,
there was a higher rate of micrometastasis with an odds ratio of 2.77. In conclusion, micrometastases were identified in 26% of patients undergoing resection of colorectal liver metastasis. Overall and recurrence-free, especially hepatic recurrence-free survival was significantly worse with micrometastasis. RAS TP53 double mutation increased the risk of micrometastasis, whereas preoperative chemotherapy with bevacizumab decreased the risk. Future directions include, for patients with RAS TP53 double mutation, to consider preoperative chemotherapy with bevacizumab to potentially reduce the incidence of micrometastasis. Further studies are needed on strategies to eradicate micrometastasis and non-invasive methods to detect micrometastasis preoperatively. Thank you very much. I'm open for questions.
The invited discussant for this paper is Dr. Valentine Fonson.
All right, so first of all, I want to thank the authors for providing me with their manuscript well ahead of time. So this is a very interesting work in a good manuscript addressing a very important topic of colorectal metastasis, particularly micrometastasis and its association with co-mutations of specific genes, RAS and P53. So we all know the liver is actually the most common site of metastasis for colorectal cancer, and about 15 to 25% of patients have distant metastasis, and another 18 to 25% develop it after initial presentation. And significantly poor survival if you have liver metastasis, which is about 11% in 5 years. So that's why this study, I think, is actually very interesting. And I got a couple of questions. This study was actually conducted in 2 institutions. So my question to you is that in your study, only the largest tumors from the patients were sectioned and analyzed. So considering the fact that there is primary tumor heterogeneity, which is reflected in the viral response to chemotherapy. What do you guys think of the validity of your results, and how could that be explained? So since you're sectioning just a large one, and you know, with tumor heterogeneity, the response to chemotherapy is different. And also, how did the authors make sure that the margins of the 2 centimeter was achieved by all the surgeons, and how was that standardized? In addition, considering that more aggressive tumors tend to metastasize in a more aggressive manner, was there any consideration in correlating the tumor biology, which means like the tumor differentiation, with micrometastasis? And thank you. I think this is really good work.
Thank you for your important comments and questions. So you're right that for patients with multiple tumors, we only evaluated the largest metastasis, which is a weakness. Prior studies have shown that the larger the tumor, the higher the incidence of micrometastasis. And so by evaluating the largest tumor, we believe we have reasonably captured the smaller other metastasis. For your second question about when we don't have a 2 centimeter margin, so we enroll patients where we were anticipating a 2 centimeter circumferential margin. And in situations where that was not possible, we cut the specimen as far out radially as we could. Again, other studies have shown that the micrometastases tend to occur very, very close to the gross tumor. And so using our method, we do believe we have captured most micrometastasis. And then your third question about correlating tumor biology with micrometastasis, we did not specifically look at tumor grade. Our prior study on resection of colorectal liver metastasis did show that RAS TP53 was a stronger predictor of survival, and a surrogate marker of tumor biology compared with other clinical or pathologic factors.
Okay, all right, Dr. Moore?
Lord Denver, very nice presentation. My recent reading suggests that there's work ongoing about the regulation of the so-called tumor microenvironment, and specifically suppression of T cells and the expression of the PD-L ligand. I'm curious what your view on that and what the current status of immunotherapy is with respect to tumor recurrence.
So the initial studies on non-microsatellite instability high colorectal cancer showed that immunotherapy was really not that effective for various reasons that we're learning more and more about. We are conducting clinical trials for non-MSI high patients where we're trying to, as you said, regulate the immune environment so that immunotherapy could be more effective in these patients.
Okay, next.
Hi, Sky Mayo, OHSU Surgical Oncology. I think an excellent presentation by Dr. Shun, and I think the group at MD Anderson, Dr. Baute, who really continue to push progress in this disease forward. I have two questions. One, I think in hepatobiliary oncology we have this problem of understaging our patients and this micrometastatic disease burden that exists. Take the patient in the operating room and then they, quote, have a recurrence. And it's really just progression of this micrometastatic disease that you see. So will there, with more sensitive modalities coming out like PET MRI with EOVIST, et cetera, do you think this will improve our ability to detect and better risk stratify these patients? And then now two, we have two phase 3 randomized trials with EORTC 40983, the recently reported JCOG 06 trial that came out, showing no overall survival benefit for patients that have resectable colorectal liver metastasis, just a progression-free survival. So how do we incorporate your findings with this? Should these patients be selected for liver-directed therapy like HAI to help treat this micrometastatic disease burden? Should they be profiled up front with this for selection? Thank you.
So I'll start with your second question about this long run debate about preoperative chemotherapy. And I think one of the issues with the randomized trial is how you define what is considered resectable. And much of our patient population is really borderline resectable. And so for those patients, I don't think there is a debate of giving neoadjuvant chemotherapy. To answer your second question about better ways to stage patients so we can identify these micrometastases preoperatively, we currently are not doing radiologic studies, but we are using more and more ctDNA, and so that may be a very promising method in the future to identify, okay, this patient has more disease than what we think we see on the CT scans.
There's one over to the left.
And, well, Dr. Schmidt has a question.
Yeah, congratulations on the study. Very interesting. The survival rates were dramatic between the micrometastatic and non-micrometastatic. So two-part question. One, how variable in the micrometastatic group was that survival? I mean, often you'll see, there's a lot of variability, but then, that's, the middle ground. And if it was pretty homogeneous and not really variable, in terms of re-resection strategies, we often get asked to consider re-resection, in these patients that recur. Should that be a no if they had micrometastatic disease in the first resection?
Yeah, so it was pretty homogeneous. If you had micrometastasis, the recurrence rate was across the board high. And then that's an excellent question. We have not looked at the patients with micrometastasis at what happens when they do recur, if any of them have had re-resection. And so that would be very interesting to look at.
Oh, another question over there, sorry.
Yeah, Jan, great presentation. One question, has your findings changed your post-resection treatment strategies?
Oh, that's an excellent question, and it gets back to what Dr. Mayo mentioned is about, do we need to rethink intrahepatic arterial chemotherapy for patients with micrometastasis?
That's the question, the million-dollar question, I guess, huh? Very interesting. Any other questions? All right, thank you very much.
Thank you.